In the late 1970s, physicians started using ultrasonography in the clinics. Instead of ionizing radiation, ultrasound uses sound waves. It is a powerful technique which allows us to visualize internal body structures. In some cases, the use of a dye or a contrast agent can enhance the quality of images, save time for the patient, and allows for more accurate diagnoses. When the FDA approved the first contrast agent in the US for use with ultrasonography in children just a few months ago in April 2016, that marked a huge leap forward for the field of medical imaging. Today, I have the pleasure of chatting with the lead author of the white paper that was submitted to the FDA in 2013 and a world expert in contrast enhanced ultrasound. Hi everyone and welcome to Doc Talk. Please welcome my guest at this time, Professor of Radiology at Penn and Chief of the Division of Body Imaging at the Children's Hospital of Philadelphia, Kassa Darge. Dr. Darge, welcome to the show.
Thank you so much for inviting me. It's a real honor and pleasure to be here. And I'm particularly impressed that this activity is being conducted by a junior medical student, which makes it even more special. Thank you for the invitation.
Thank you so much for being here. It's a pleasure. So, Dr. Darge, if I recall correctly, you got your medical education in Ethiopia, then went to Germany to pursue your PhD work, where you were on the faculty for close to a decade. And today, you are the chief of a division at the Children's Hospital in Philadelphia. What events brought you to Penn and Philadelphia?
There are a number of steps in my career that now you're talking about spanning of almost 25 to 30 years. As you mentioned, I did my medical education in Addis Ababa, at the Addis Ababa University in Ethiopia. And when I graduated from there, I was assigned as a faculty to a newly opened medical school in the western part of Ethiopia in Jimma. And so I really started my career as an academic medical doctor. While working there through circumstances related to my past, which is I was formerly a student of the German school in Addis Ababa, and I spoke fluent German. I had made the acquaintance of a German tropical medicine professor who visited Ethiopia. So after a certain delay, he offered me WHO fellowship. That's a fellowship from the World Health Organization, a research fellowship in collaboration with his institution in Germany, which was the biggest and oldest institute for tropical medicine, the Bernhard Nocht Institute of Tropical Medicine in Hamburg. So because of my interest in research, which I had even before, I thought this was a great opportunity to pursue as a young doctor a few years out from medical school. And so I accepted that position and went to Germany to work with him. The work with him entailed working also in West Africa, where the Institute had research outposts. This included work in Liberia and in Ghana, where I spent considerable time. And during this whole research fellowship, I was also able to get my diploma in tropical medicine. And so during my time while actually working in Liberia, I had the fortunate situation of collaborating with other colleagues from Germany, from the University of Heidelberg, who were working on the same topic that we were working. It was filarial disease, onchocerciasis, who came from the Department of Radiology of the University of Heidelberg to conduct some studies in collaboration with our group. So the chief of the pediatric radiology, who I met there and saw me working there, actually offered me to come to him So I thought long and hard and decided to complete my tropical medicine and then move over to radiology and start actually radiology residency at the University of Heidelberg. 7 years into my position, circumstances changed for my family. My wife, who was software engineer, was busy working in Germany with me, and she was working for the Department of Defense of the United States in Germany. Through her work, she was assigned back to work in Washington, D.C. So it was a struggle. Two professionals in the family, what to do. And she was so generous. She had moved twice because of my change in positions. Once from America, she moved to Germany. And then from when I finished from Heidelberg University, she moved with me to Würzburg. And the third option was now for me to decide what to do. It was hard to decide. So I commuted from Germany to Washington, D.C. every month for a week. I did it for a year. And that's why I always laugh when people say they commute an hour. I say, wow, I commuted between continents and realized it was something you couldn't do for good. So that's when I started looking for opportunities around the East Coast and de facto landed in Philadelphia at CHOP.
That sounds like an incredible story. So thank you so much for sharing it, Dr. Darge.
When I graduated from the medical school and was assigned to work in the Western Ethiopia, my first research experience really that was initiated by myself and which I conducted on my own was I was assigned to a military base as the chief medical officer in this southwestern Ethiopia because of an outbreak of meningitis in the big camp. And this was a humongously big establishment with over 100 patients with meningitis that were admitted. So at that point, I was alone. I was the chief medical officer having to deal with all the meningitis epidemic and all the complications for the military. So I made decisions to revamp the whole hospital to accommodate all these patients who were coming day after day with all the complications. And that gave me an opportunity really to put together all the data from this happening even during such an epidemic, because it was such unusual constellation of medical problems at one time.
How easy was it for you to find mentors? And what is it like being a minority figure but a division chief at a large academic medical center?
I had been extremely fortunate to have a phenomenal mentor by the name of Professor Johann Tröger from the University of Heidelberg, who was selflessly committed to advancing his mentee's career. So that actually is one of the experiences that drive me to commit to mentorship. So I had the most positive mentorship, and that is exactly what I want to give back. So that's one thing. On the other hand, also, in Germany, the academic structures at universities and being a professor at the universities, the whole system is really intertwined with mentorship, mentors and mentee. It is something you can't separate from academic medicine. To the extent there is the word in German, if you have your professor who's mentoring you, and that's part of your obligation, duty, privilege, and honor, that's the way it's regarded. What you call him is Dr. Vater, meaning the doctor father. He's a father of your doctoral thesis. So that's the relationship you have. And these are the people who really mentor you to grow in your career, to write your papers, to do your research. So these are, it's part of it. So I came from that system here. So that was, for me, a self-evident thing, which when I came here was actually, for me, surprising to find that this was far from the daily reality. There was no mentoring structure. There was no understanding that there is a need for mentorship, the value of mentorship, the need for guidance of young colleagues to be able to be promoted. People didn't know the promotions criteria. Yeah? People didn't know that it was imperative to prepare for these years ahead. Yeah? Even though the university had all these criteria, people were not aware of this.
And this is here at Penn?
Here at Penn. We're not aware of this. They knew one time you get promoted, you may put the papers together, but years before you were not aware and you were not preparing for this.
Mm-hmm.
So for me, that was a big eye-opener. And then mentoring means you support that person to grow, and growing is a process. It's not a one-time thing. So to see it from a very young, grow and mature as a doctor, as a scientist doctor, it is a long phase. So what I put in was a mentoring structure for the radiology department. What that meant is that, first of all, we identified at the beginning primarily the assistant professor colleagues, so young colleagues who just graduated and who had been appointed as assistant professors. So then we identified people who would support them, as mentors. You ask them. So we put a mentoring committee. Usually the mentoring committees constituted from 2 people who are from the department and, if possible, 1 person, a clinician outside the department. So it's a mentoring committee. What are the duties of the mentoring committee? The mentoring committee would gather, depending on once or twice a year, and discuss the development of the mentee. That's the official. Outside that, particularly the primary mentor, who is chairing the mentoring committee, would have the closest relation with the mentee and go over things they do and support them, or collaborate with them in research in any aspect to promote that. Okay. So we meet to discuss ways to promote the young faculty member in their career track, so that they can, throughout their time, gradually develop all the necessary work that would make them grow, and when the time is ripe, make them easily promoted to the next higher level.
You mentioned that research was something that you now actively promote in your department. It's something that is a part and parcel of your education process, and I imagine it must be extremely fulfilling when something that you work on makes its way to the consumer, the patient, the market. And as I mentioned at the start of the episode, you were a part of one such large effort which led to the approval of the first contrast agent for ultrasound earlier this year. What was that process like?
Ultrasound contrast agents are tiny microbubbles. These are really bubbles like you would see bubbles in champagne, but they are very, very small. They are much smaller than red blood cells. And these microbubbles, if you take 1 ml of the ultrasound contrast agent, in 1 ml, you can find of some of the contrast agents 600 to 800 million microbubbles. So they're very, very tiny. So when you inject them into the body and when you do ultrasound, these microbubbles light up. They are like, depending on the modality used, like many white dots. So they can show structures, and they flow through the blood vessels. So what happened in the United States through the FDA that was something phenomenal and very special was the fact that the FDA approved the intravenous use of ultrasound contrast agents in children. The ultrasound contrast agents have a number of benefits for children. Ultrasound per se in children is widespread, and one of the driving factors is that the body size of children is smaller, so the penetration of ultrasound is much better even than adults. Yeah? So you can use ultrasound for many applications in children that you might not even use in adults. So if you can expand the diagnostic potential of ultrasound, you are helping many children have the benefit of ultrasound.
The rate at which the field of medical imaging is evolving comes with pros and cons. Right? In the past, I remember when interns and residents in internal medicine would be taking rounds, they would just enter one of the rooms where a bunch of radiologists would be reading images. They would chat for half an hour or an hour, and that exchange of information would be tremendously valuable for both parties. But more and more, it seems like the two communities are working in isolation in their own space, and that interaction seems to be dwindling down. What is your take on that?
This is a really true situation. I mean, this is what is happening of digitalization and everything becoming electronic. So now, like the electronic medical record, we have what is known as a PACS, Picture Archiving and Communication System. And that allows us to have all the images available on screens. We don't have any more films. And this is allows us to sit anywhere and read the films. And as you rightly said, it takes away the direct interaction with the physicians. And one of the reasons is they have also a similar access to the old images electronically from anywhere, from their mobile gadgets or any other system. And the motivation to have to go to the radiologist to discuss it is not there, or the need may not be there. However, we have the clinical conferences with different divisions. For instance, every week we have a conference with the urologist. So complicated cases are presented there, the images are discussed, so radiologists are there, urologists are there, trainees are there, and that gives us opportunity to discuss. In addition, recently, through the work of my colleague Janet Reed, we introduced virtual rounding. And that is the ability to do the rounding where in the times before we used to go to the ICUs, that we now do virtual rounding, sitting at the reading station, but communicating directly like a video conference with the ICUs who see us, and they discuss cases. And this we do multiple times in the week with the different ICUs in the hospital.
So along similar lines, now that the access to images is so easy that one can access them remotely, a growing concern in the field seems to be that, soon machines will take over the work of the radiologist, or radiology is a field that's, going to die very soon.
This is certainly an issue that has been raised or is being raised by many, especially in the recent times. I think if you're outside radiology, it might be easy to simplify the process. If you're inside, you know all the limitations and the potentials. From my long experience and from the current development and future potential changes in radiology, I think a whole replacement of a radiologist with a machine is very, very far away. I mean, that's something I don't even expect in my lifetime. Why? Like, you have a clinical medicine, which is not black and white. The radiology reflects the same thing. It's not black and white. There are many, many variables you may consider. Yeah? And even after considering that, you may need to sit down and discuss with the clinician to make sense of the findings. So to claim that you can sort of put a robot for all the activities of radiologists, I think it's a little bit naive and a little bit far-fetched. There are definitely certain things that machines can do or even do better. For instance, you may use an automated 3D post-processing software to process it. That may be better than a human doing it manually. You may use a functional analysis program to analyze it than doing it subjectively, definitely. Yeah? And you may be able to detect certain lesions on an X-ray with a machine. Yeah? But even those recent studies have shown may not be able to compete with the human analysis. So, I mean, there are definitely certain aspects, but it will not be a full replacement of the human input in the radiology process.
Well, thanks for sharing that, Dr. Darge. Next, I want to move on to what I call a rapid fire round. So in this segment, I'll ask you a set of questions, and your task is to come up with the first response that you can think of. What is the most challenging aspect of working in an international community that people often underestimate?
Understanding the culture of the different components of the community.
One piece of advice that you would give to someone who is interested in becoming a radiologist?
Start early on to look into the field, yeah, and network and prepare for it.
What are important aspects of designing a clinical research project?
First of all, it has to identify the problem. And the problem, especially in clinical research, should be a real problem, not imagined problem. And the solution you're looking for is a real solution to that problem, that once you find it, that you can implement it in your practice. So these things need to be considered when selecting a study or planning a study.
What aspect of your life in Germany do you wish you could bring with you when you came to the United States?
The absence of the need to commute and just drive with your bicycle and go to work.
Well, thank you so much, Dr. Darge. Those are all the questions we had for you today. Radiology comes with its own challenges and opportunities, but beyond a doubt, it is an area rich for both scientific discovery and clinical impact. Hope you all enjoyed this conversation, and please stay tuned for our next episode. Until then, this is Divyansh Agarwal signing off.